Some viruses don't go away. They stay hidden in your body for years and can come back when you least expect it. In this episode, we talk about ocular herpes, how to recognize them early, why some treatments fail, and which mistakes can lead to permanent consequences. This is information that truly matters.
Welcome back to part 3 of my conversation with Dr. Mika Moy. In this episode, Dr. Moy explains current treatment for herpes zoster ophthalmicus or eye shingles. There's some interest in using a fluoroquinolone with simplex. Tell us about that. Do you think there's any validity to it?
So I remember when fourth generation fluoroquinolones first came out. Remember when Vigamox came out, it was moxifloxacin, and they said bacteria will never develop a resistance to this because it has two mechanisms of action. And I thought to myself, oh, you're going to hate those words because bacteria are going to eventually evolve into something, right? It took a while, but they did. So it turns out fourth generation fluoroquinolones have two mechanisms of action and they stop bacterial replication. It turns out that herpes simplex uses one of those methods of replication. So even though a fluoroquinolone is an antibiotic, it actually has antiviral properties with herpes simplex specifically. It won't work with viral conjunctivitis, the common cold in the eye, but it actually has some efficacy. Now, it's not nearly as good as an antiviral. Fluoroquinolone should never be used as a primary treatment or an only treatment. However, remember how I said I missed Vira A? The reason why I missed Vira A is because there are actually antiviral resistant strains of herpes. Now, this is not happy news, but when you have a herpes infection that's resistant, it's different than a bacterial resistance. So bacteria, you introduce an antibiotic, all of them die except the one mutant that is resistant to that bacteria. Then that one bacteria creates the millions of bacteria just from replicating. Now, all those millions of bacteria are resistant to that antibiotic. So you introduce a new one. All of them die except the one who's mutated now to be resistant to that one and this one. And that guy replicates. That's not how it works with HSV. HSV, when it's dormant, in between exacerbations, it lives in the trigeminal ganglion. What is that? So your fifth cranial nerve is your sensory nerve, and it has three branches that sort of divide up your face into what it feels, right? It tells you when something is scratching you. It's the sensory nerve. It all backs up into the trigeminal ganglion, which is sort of like, I'm going to call it the mothership. So when herpes is dormant, it hides in that trigeminal ganglion. It hides in the mothership, and that's where the antivirals can't get at it and your immune system can't get at it. Then when it reactivates, it sends the soldiers down to your face to cause trouble. So when people have resistant HSV, let's say 10% of the virus living in the trigeminal ganglion is resistant. You kill all the stuff over here, it doesn't change what's going on up here. So the next episode you have, only 10% are resistant again. And the next episode you have, only 10% are resistant again. So most people don't have HSV that has resistance. Some immune compromised people are the ones that more so will develop HSV that has resistance. But the first patient I ever had who had resistant HSV, she came in and she said, I have that herpes thing again in my eye. And I looked, I'm like, I concur. I think your diagnosis is correct. And she says, now I need that V medicine or it won't go away. And I thought she meant Veroptic. And so I was like, silly girl, I'm going to put you on a Zoster dose. Watch how this thing, it's going to be great. She comes back for her follow-up and all of it was gone except this one little spot. And she goes, I need that V medicine. Hold on. I looked it up. It's it's Vigamox. And I was like, well, that doesn't make no sense. That's an antibiotic. So I said, okay, hold on. I'll be right back. And I go to my computer and I do a PubMed search to see what's up. Oh, there it is. And so I sat there and I was like, well, I don't know what dose to give her. Let's give her a high dose. Put her on Q1H in that eye. She comes back. It's all better. I was actually also thinking whether or not I should debride that area to get it to go away too. I decided not to take off that little spot just to get the viral load off of there. But she did beautifully. So now whenever she comes back, and she comes back usually every couple, 3 years, I start her at the beginning because I know that's what she needs for that to go away. I've only had in my career maybe a handful of patients who had a little bit of resistance in their eye. And so I use that medicine adjunctively when I need to, but I won't know that I need to until the follow-up unless they've already been my patient. Does that make sense?
Sure, and it's interesting. So you'll use the V medicine, Veroptic. We use any other oxyfloxacin or Bessie, or we use Moxie. Uh,
So yeah, I don't know. Bessie's expensive still, so I tend not to go there unless I'm really worried about something. Um, I tend to use moxifloxacin, but that's a formulary thing for me. I know they have it on the shelf in the pharmacy, which is downstairs from where I am. So I don't have experience with the other fluoroquinolones. Um, but the longer they've been around, although Besavance is still pretty, well, I'm talking about bacteria now. Besavance still is almost a silver bullet still for us.
with more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MySight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. It's interesting you mentioned debridement. Back in the day, that's what we used to do. We used to debride the area. I guess nobody does that anymore.
Do you know some cornea specialists still will,
They
but I
do.
tell you, especially if there's a huge dendrite, I have known some cornea specialists to still do that. I haven't noticed if they tend to be of a more mature generation, and maybe that's like an older technique.
Bec-
But I tell you what, I have had such good experience, and quite honestly, this whole like use the Zoster dose instead of the simplex dose. Um, when I was a resident. I was actually a pediatric and resident, but my secondary area was cornea contact lenses. And so one day a week, I would go to UCSF med school and I would do cornea rounds at lunch with all of the ophthalmology residents, which was super good fun. And so that's where I learned this. And I was talking to one of the cornea attendings, and I had just graduated, so I knew simplex dose, zoster dose. And so he asked me a question. I answered it with a textbook answer, felt pretty proud of myself. And then he asked me the question, like, why wouldn't you? He's like, do you know in this hospital, standing order is you use the zoster dose and you have to convince me why you shouldn't. And I was like, and that was the first time I had heard that. Why wouldn't I? Should I? And so then I brought that back when I became a faculty here. And, you get pushback at first because it's a new idea. But now I think I've convinced everybody at this point. So when you see how quickly the patient responds, debriding seems mean. That hurts. And if I give you a zoster dose, these dendrites melt away. And so I don't think it's necessary, really.
I don't think so either. In fact, back in the day when we used to do it, we used to get some people that wouldn't heal because we did it. I think we did damage and
Mhm.
wouldn't heal. So, I obviously try to avoid it. And I have never had to do it anymore. So there are new drugs in development instead of 3 times a day now, or 5 times a day. Now you only have to use them 1 time a day. They're in development, but that seems pretty interesting. Can you talk about some of the new drugs for herpes simplex in development?
Yeah, so these drugs are going to be for simplex and zoster. There's actually two that actually have names. So in the United States, we tend to get the good stuff after all the other countries already have it. And that's because our process of approving a new drug is a lot more stringent, I would say, time consuming, money consuming. So, oftentimes, when a drug company is researching a drug, it gets like letters and numbers for its name. And that kind of gives you an indication of where they are in the pipeline. When it gets an actual word or a made up word for a name, they're sort of closer to the end. So, one of the ones that's probably the closest has the name of a menamavir. And I think the other one is pratilavir. So, one thing that I noticed, and I don't know if you noticed this too, is everybody who was working on infectious disease stuff got distracted when COVID showed up. And it seemed like everybody stopped whatever they were doing and went over there. And thank goodness, because, that pandemic could have been uh, lasted longer and done worse if we hadn't developed the things that when I say we, like I had a part in it, that they developed as fast as they did. So I actually thought this drug was going to be here already before the pandemic. They're pretty far along in their process, but uh, I believe it's Japan. It's already available in Japan, and has been for a while, and they're seeing quite good results. And can you imagine if, taking fewer, going from 5 times a day of having to take a drug to once a day, that would be lovely. Um, but the other thing is it has a different mechanism of action than the ones that are commercially available in the United States right now. So now when I have that patient who needs her Vigamox, her V medicine, because she has some resistance, when this medicine comes out, then that might be something that we could do instead. And then that way she only needs to do one thing because the mechanism of action is different. So I'm pretty excited, but as with all drugs in the United States, when it comes out, it's going to be super expensive and probably insurance companies aren't going to pay for it until you fail on traditional treatment that's so much cheaper. So we're going to have to do all that stuff too. But I'm excited for these medicines and these novel treatments to be available to us in the United States.
Well, let's turn our attention towards Zoster. We talked a lot about Zoster. It's confusing because they're both herpes, and one's simplex, one's Zoster. So it does get confusing, but you had somebody who had Zoster. This is very, very important. There's a prodrome phase.
Yeah.
And so you got to diagnose it early for the treatment to work properly. So the earlier diagnosis, the better it's going to work. If you wait too long till you have all the scabs and all the problems, it's you're looking for trouble. You're looking
Yep.
for post-herpetic neuralgia. You're looking for a long course of a disease. But if you could catch this early, you could stop it. So talk about the prodrome phase. What are people going to feel before they get shingles, zoster or shingles?
Yeah. So people describe it as malaise, headache, fever, flu-like symptoms. But I'll tell you about my prodrome. So I was feeling off, and then I was trying to get up and start my day. And I sat up and I was so dizzy, I fell back down onto the bed. And then I was like, whoa, that was weird. So I tried to sit up more carefully, and the world was spinning. My head was throbbing. I felt like I had a headache. And I actually, my husband used to work East Coast hours. And so I was in charge of getting the kids to school, and he was in charge of picking them up at the end. I actually had to call him and be like, you need to come home from work because I don't think I can get the kids to school. Because they were little back then. And I was like, this is the weirdest flu ever. This is the weirdest flu ever. And then the morning that I woke up, looked at, and I actually brushed my hair out of my face, and it felt like a lightning bolt from my touch went here and zapped the back of my head. And that's what made me look in the mirror and see the telltale rash. Now, would I have been able to diagnose myself had I given credit to the prodrome? Like I asked that question of my patients, were you sick last week? And they go, oh yeah. And I never really felt that in my bones till I had it. Because it was like the worst flu ever. Like I thought I've caught something very bizarro. And this is before COVID, with my episode. So that lightning bolt was the first time I had felt that, and then I had the very early stages of that rash show up. So I think for doctors, it's difficult to diagnose it until you see the rash. But you are absolutely right. If we can start the antivirals within the first 3 days of the rash showing up, outcomes are tons better. If we start the antiviral and we're on day 4 or 5 or longer, then we don't shorten the course. It doesn't, it's not good. There's more chance of postherpetic neuralgia, complications, etc. So early diagnosis is really key, but that means we need patients to come see us early and not, there's a lot of this, I'll wait and see if it goes away, kind of stuff that goes on.
So the patients that are listening to us, the public that's listening, they get a burning in their skin, a tingling in their skin, a boring pain, but they don't have any rash. That's something that they have to go to their doctor and talk to their doctor about because that means they may be getting zoster.
Absolutely correct. And the older you are, the biggest risk factor is age. So the older you are, the more likely you are to have an episode. You need to have had chickenpox, right? So shingles is actually the chickenpox virus reactivated. Now, people of our generation, we all had chickenpox the good old-fashioned way. people of the newer generation, there is a vaccine now that was it came out in the mid 90s. It was people were super excited about it. And it had uptake in the United States. It was very well received, and parents were getting their kids vaccinated. The number of chickenpox cases declined dramatically. And, something like 100 kids would die every year from chickenpox. And that practically went to zero once this vaccine showed up. So, so we who got chickenpox the old-fashioned way, our cases of zoster is very typical. It's what you hear about. It's very painful and awful. For people who got the vaccine, so these people are now my optometry students. They're now in their 20s, maybe slightly older than like 20. They're not yet 30. We're getting there. Can they get shingles even though they were vaccinated? Yes. But the shingles that they get is much less severe. In fact, I have a couple of patients, and again, I think I'm seeing this sooner than everybody else because my practice is flip-flopped. Most optometrists, their practice is mostly people over the age of 40 and then some youngins. My practice is flip-flopped because of where I practice. So most of my patients are under the age of 40, and it's less typical for me to have patients over the age of 40. So I started seeing these patients come in, and I would be like, that looks like zoster. Are you in pain? No, I'm not in pain. I would put them on an antiviral anyway, and it would go away super quick. And oftentimes, because these kids are so young, they'd be like, look, I have funny acne. That is not acne. That's not what that is. Um, so I started to do some research to be like, is anybody else seeing what I'm seeing? And the CDC is not ready to make bold statements yet. They say they have something that's soft, like it seems to be less frequent for vaccinated people to get zoster and less severe. But I think what we're going to see based on what I'm seeing now, since these kids are in college now, and so they're my patients, um, I think it's odd that they're actually seeking care, depending on how bad this rash that they get is. Um, and so I bet you there's a lot of kids who are getting zoster and they don't know it because it doesn't hurt. Not everybody who has had the vaccine gets painless shingles, but that seems to be what we're noticing. And then also, when you look at the literature, it turns out that one thing that we can tell is when you got chickenpox the good old-fashioned way, even though most people didn't get shingles until they were elderly, it was possible to get shingles anytime after you had chickenpox. I got chickenpox when I was 3, so theoretically I could have had shingles when I was 4. I waited till I was 43. That was still kind of young. But when you look at cases of childhood shingles and you look at unvaccinated versus vaccinated, those case numbers have gone way down. And so I suspect as these people get older, the cases of shingles will go down a lot, which means the cases of postherpetic neuralgia will go down a lot, and it's going to become like a medical mystery. It's interesting that the disease profile of this disease has changed so much because of 2 vaccines. We have a chickenpox vaccine, and now we have a shingles vaccine, and we have a shingles vaccine that is much better to the point where they retired the first one. So the new shingles vaccine is called Shingrix. Okay, so I got shingles when I was 43. That was not a pleasant event in my life. You're not allowed to get Shingrix until you're 50. You used to not be allowed to get the old shingles vaccine until you were 60. And the reason is because they don't want the efficacy to wane once you're significantly elderly and you get postherpetic neuralgia and shingles, then that would be bad. So they make you wait a little bit, right? So when I turned 50, I go to my primary care doctor and I was like, I want that vaccine because I don't want to do this again. And she said, how long ago was it now? 7 years. She goes, all right. So she let me have the vaccine. It's a 2-shot series. The first shot, my arm really hurt. The second shot, I needed to have a day off of work because I felt pretty sick for that second shot, but it came and went sort of like that. Well, there's new data out of Stanford. Very interesting. It got published in Nature, and then a follow-up got published in Cell. So you know that those are the premium journals. They don't take the riffraff. They only take really interesting, well-done studies. So there is evidence now to suggest that getting your shingles vaccine decreases your odds of dementia.
Really?
I want that. That sounds good. And they looked at Wales. So they were over in the UK. And this thing happened in Wales that was interesting, where there was a shortage of the vaccine. So they said, if you're 79, you can have it. And that was it. So people, there was a rush. They were like, oh, I want my vaccine because if I turn 80, I'm not allowed to get it anymore because there was a shortage. So what that ended up giving them was like a control group, right? Because 79, 80, there's not too much difference there. And it used to be that whenever you did vaccine studies, it's difficult because the people who choose to get vaccines tend to live their lives differently than the people who choose not to get vaccines, right? So there were all this noise in the data that you couldn't account for. But they looked at every other thing that could be causing this decrease in this particular population having dementia. And it's a pretty good amount. I want to say it's like 20% less risk of having dementia. It might be 30%. Everyone should go read this study. It's fascinating. Um, and so now, everyone's looking at what causes dementia. There's all these great ideas, nutrition, diabetes, all these things that can contribute to people developing dementia. Well, now it's like, what about viruses? What about inflammation? Maybe it's not the virus, maybe it's the disease process because fewer people had shingles, so fewer people had the inflammation. So I think it's opening up a really interesting avenue that we need more research in. But I encourage you, you don't want to have shingles, trust me.
Believe me, I don't want it. So about a third of the population gets shingles, and
True.
what is it, like over 85, about 50% of the population gets it. So
Mhm.
it's pretty common. And talk about like the dermatomes that it affects. When people first get it, they'll get it in one or two spots, one or two dermatomes, which is a dermatome is a territory for each nerve. But if you get in more than that, then you're immune compromised. And typically, when people would get shingles when they were younger, they might have cancer, or they might have had a hidden immune compromise because typically people would get shingles when they were much older. Of course, there were exceptions like yourself, but if you could talk about that a little bit.
Thank you for saying I'm not much older, or I wasn't much older in my 40s. Sometimes I feel like I'm looking at the retirement age getting closer and closer and being like, wow, am I really thinking about this? So,
Go
uh,
through it. And if I do the calculation, I'm not going to say what I think it is, but I'm like, but you look much younger.
well, thanks. I'm in my 50s. I'm double nickels.
There you go.
Anyway, talking about dermatomes. So, when you get chickenpox, we call that varicella zoster. Uh, you get over your chickenpox, but then the virus hides in your body and it hides in these kind of up and down your spine. So as the nerve endings come out of your spine, they feed certain areas of your body. We call these like the dermatome area of your body. So when they're hiding, they express very few genes. They sort of like they're dormant a little bit. That's why your immune system can't find them. When they reactivate, uh, as shingles, they will be usually on one side just because of how your anatomy of your nerves work, right? So it'll reactivate on one side and then it'll be in a very specific area. So the most common dermatome to be affected is thoracic, so somewhere around your ribs. And the rash will usually be either on the front part of your body or the back part of your body. And it'll be in a very uh, focal geographic area and it kind of fans out from your spine. Uh, you can get shingles on your face, which is what I did. And then the dermatomes are from trigeminal. So I had ophthalmic, which is this part, which of course I did because I'm an eye doctor. Then there's the sort of the center part, the upper part of your cheek, and then down here on your chin. So when people get shingles, they usually might have one dermatome or one dermatome and the one next to it is what's affected. As soon as you have three dermatomes or more affected, now we're worried about your immune system. Like, why did your immune system allow so many of these we're gonna call them nests, these nests of hiding shingles? Why did your immune system allow them all to activate at once? Your immune system might have a problem. We better check it out as we're treating you, for the disease. That's something that we would take a look at. And when you have friends who have had shingles, they'll tell you stuff like, I couldn't even wear clothes because anything touching my skin was so painful. I couldn't lie on my back. I had to lie on my stomach because this rash was on my back. And it becomes it incapacitates you. It has the potential to for a while just because any movement causes pain. When I had my shingles around my eye, I almost wanted to just like, put my hands in braces because every time I just wasn't thinking about it and I would like get my hair out of my face, I would get this shooting pain that went to the back of my head. But if I left it alone and I didn't raise my eyebrow too much, like it was manageable. But I was on pain meds, I was on antivirals, and that's typical. One of the main ways that we need to help patients with shingles is not just to kill the virus, but it's also to manage their pain.
How do we know if shingles is going to affect the eye?
That's a great question. So, first of all, the only way that shingles is going to affect the eyeball itself, is if the ophthalmic division is affected. So if the rash is like here on the forehead around the eye, then we're worried that the eyeball itself will be affected. But what a lot of people forget is the ophthalmic division also covers the top of your nose. So going down the top and down the side of the tip of your nose. So there's something, students, listen up. There's something called Hutchinson sign. Hutchinson sign, I'm sure, was named after some guy named Hutchinson. But I think the reason why it's taught a lot in schools, maybe asked a lot on tests, is because people don't associate the tip of your nose with your eye. So if you have Hutchinson sign, meaning that one of these scabs or rashy areas is on the tip of your nose or down the side of the tip of your nose, that makes that you have to remember that's ophthalmic division. So we're still worried about the eye. Once a patient, let's say that the eyeball itself is not affected yet, and you start the patient on antivirals, the rash is just on their skin. Uh, it's unlikely that it would then jump into the eye. However, it can once the antiviral is started. And remember that the cornea findings can come months after the rash is gone. The patient thinks they're all done, and then the cornea kicks up. So it's still something that eye doctors have to be aware of. And patients out there, if you had shingles, you need to, next time you're with the eye doctor, you need to tell them, when did you have shingles? And what was it like? Which part of your body was affected? Especially if it was on your face, you need to make sure that your doctor knows that, your eye doctor knows that.
And what other parts of the eye could it affect shingles?
So I have a joke with my students, and I say, if you get asked on a test, what diseases can affect this part of the eye? Any part. I go, you can, and you don't know. You can always guess Zoster or syphilis because those things can affect, it seems, every tissue in your eye. So Zoster, it can affect the front of your eye, the back of the eye, the inside of your eye. It can create inflammation in like every place can be affected by zoster. So if you have shingles, patients out there, your doctor's going to want to dilate your eye and look inside it as well to make sure that your retina is not being affected, to make sure that the aqueous or the vitreous, that the sort of jelly fluid stuff that fills your eye is not affected. And they're going to want to watch you pretty carefully because there are other medicines that need to be introduced if those tissues start to be affected. Zoster can permanently mess with your vision, and so it's something that you need to be careful about.
And which do you think is worse for your eye, Zoster or simplex, has more commonly worse for your eye?
I think that I would, if you said to me like which one would you like, I'm the devil and you have to either pick having simplex in your eye or zoster, I would pick simplex. And the reason is because even though simplex can affect parts of your eye, it's mostly going to stay on the surface. Zoster is more likely to cause trouble, and sneaky trouble, meaning that sometimes zoster will cause a condition, let's say scleritis. Scleritis is an inflammation of the white part of your eye. And that can happen years after you have an issue with zoster, or it could be the only manifestation of your zoster. Well, that's tricky, difficult for an eye doctor to look, and they'll be able to tell you have scleritis. They'll be able to treat you for it, but most scleritis is not infectious. And so it might take a while before they figure out, oh, I should also be giving you this other medicine to kill what's actually causing this inflammation to happen. So zoster is a little tricky devil. And so uh, I think zoster is more problematic.
And 50% of the people could get uveitis.
Yes. So uveitis is an inflammation of the uvea, which is a particular layer of the eye that includes your iris, and it also includes layers underneath your retina. Uveitis is tricky because it's an inflammation, and so I need to put a steroid on it to reduce it. But at the same time, the reason why it's there is a virus, and so oftentimes I won't. If the patient has a uveitis secondary to zoster, I won't treat it with a steroid right away unless I have to. If things have really gone off the rails, I will use a strong dilating drop to try to get that uveitis under control. Sometimes you have to do both. But that's a patient that's more difficult. And the thing that's interesting about both zoster and simplex, most of the time when people get a uveitis, the eye pressure in that eye goes down initially. But with zoster and simplex, the eye pressure actually can go up. So that's something that I need to monitor because a high eye pressure for too long can actually start to damage parts of the nerves in your eye, the optic nerve and the retina of your eye. So, so yeah, tricky.
Would you stay away from a type of a prostaglandin glaucoma drop because of the inflammation from
So,
Zoster simplex if you needed
yeah,
to keep the eye pressure?
that's a great question. So, prostaglandin would not be my first choice. Prostaglandins can cause inflammation, and so you have to be careful when your patient has an inflammation, but you need to reduce their eye pressure. But the other reason why I wouldn't use a prostaglandin is because its mechanism of action, it's not going to work fast enough for me. So the reason why eye pressure is going up with a uveitis secondary to either zoster or simplex is because it's tickling the trabecular meshwork. The trabecular meshwork is the drainage system of the eye. So I would choose a drop that decreased inflow. So the eye pressure is because your eye is constantly making fluid and draining fluid. It makes the fluid behind your iris and this structure called the ciliary body, and then that makes its way to the front, and then it drains the fluid from the structure called the trabecular meshwork. Um, if the trabecular meshwork is the problem, the fluid is not getting drained, then any drug that I use to try to increase that is not going to work as well. And so what I want to do is decrease the production. So I'm probably going to use a beta blocker if that's okay with my patient's history. There's a lot of contraindications to beta blockers. Or you could use like a carbonic anhydrase inhibitor, for example, if you need to get that pressure down.
If they're already on a prostaglandin, would you take them off of it?
Ooh, see, now these are eye doctor questions. This is like a trick test question. What should you do? Personally, I'd leave them on it because I don't think it's contributing that much to it. I would add, so like if they're on a prostaglandin for glaucoma already, and then they get shingles and then they have a uveitis, this is excellent stuff. I would probably just add to it. I don't think the prostaglandin would do that much. Do you disagree? Would you take them off?
No, I would leave them on.
Okay, good. I'm glad we agree. Although it's kind of fun to have fights sometimes too about these academic
Yeah, these
discussions.
academic questions, and every patient's different, and people listening, your doctor may do something different. You see somebody with their iris and they have a sectoral iris atrophy. What does that mean to you?
So, what's interesting about uveitis that's caused by herpetic disease is most uveitises don't do anything to your iris. Your iris is fine. It was upset for a little while. That's what helped cause the uveitis, but then it resolves. It's fine. What's interesting about zoster in the eye is that you get what are called transillumination defects. So your iris has a really important job. If your iris wasn't there, too much light would be entering your eye, right? And your iris is in charge of decreasing the size of your pupil, increasing the size of your pupil. So it's there to block light. But what happens is you get these transillumination defects, which show you that the iris isn't as thick as it used to be. And it almost looks like a moth-eaten appearance is usually what you'll see in a textbook, where it's like someone chewed away at that area of the iris. Now, do patients typically have a symptom for that? Like all of a sudden, do they have glare and stuff? No, not really. But if you've got your eye doctor detective hat on and you think, oh gosh, I really need to know whether or not this patient had zoster and the chart isn't telling me and the patient can't remember. That's one of the things that you can look for. Look for the transillumination defects. And if you see these large geographic sort of moth-eaten looking transillumination defects, now you know that eye has suffered from a zoster infection at one point or another, or from a zoster uveitis.
And we used to treat red eyes from Zoster with antibiotics and steroids all the time. Is that something that you would not do?
To treat zoster with an antibiotic?
Yeah, if someone had a red eye from a zoster, just to prevent like a secondary infection, that's something we used to do in the VA all the time.
Yeah, you know what's interesting is when you read textbooks and stuff, they'll frequently talk about secondary preventing secondary infections. So, for example, zoster is one good example. Another example, we were talking about herpes blepharitis, simplex blepharitis. A lot of I call them cookbooks, but a lot of textbooks will tell you to put an antibiotic ointment over the top of that to prevent a secondary infection. And I stopped doing that long ago. And the reason is because it hurts the patient to touch that. And I thought, okay, well, I'll wait to see how many secondary infections we get. I have yet to see one. So I tend not to. However, I understand that the odds of somebody getting a bacterial secondary infection, like anytime you have a corneal defect, your odds go up of getting a secondary infection. And if you're using a steroid to help manage the zoster, I can understand as to how that might not be a bad idea, especially if what you're trying to protect is the cornea.
Now I have to ask you this. This is amazing. Tagamet to help with Zoster. This is actually amazing because but it does have a receptor. The T suppressor cell has an H2 receptor. So it does help with Zoster patients. Talk to us about that. This is amazing. Over
So
on the Tagamet.
I wish I had known about this when I had my case. This is something that has was written about, I believe, in the 80s. So it's been around a while. The reason why it doesn't have more press and the reason why more doctors don't know about it is because there is no placebo-controlled prospective study on it. This is sort of it makes sense on paper, and doctors who use it will anecdotally tell you it works really well on their patients. And I tell you what, if I had known about it, I would have put myself on it when I had zoster. But Tagamet or Cimetidine is an over-the-counter medicine that's used for gastric upset. It's an H2 inhibitor. But as it turns out, as you say, that actually that has to do with your immune system as well. And so what this paper found was that it's when you put people on this, and by the way, you have to use a higher dose than the over-the-counter dose. So you need to be careful. If you look at the potential side effects for Tagamet, it'll say stuff like use with caution in people with kidney disease and liver disease. And most people who have zoster are older, so they're going to have more issues. So you need to proceed with caution, doctors out there. But uh, anecdotally, it seems to provide faster pain relief, faster healing of the skin, but you need to use 400 milligrams TID, which I think is more than double what the over-the-counter dose is. So proceed with caution, but how wonderful would that be? Again, we don't have any prospective placebo-controlled studies, which is why I think this isn't written into cookbooks a lot. It's not in the textbooks a lot. And the latest study that I could find, or it was really more of a article, it wasn't really a study, was from the 80s. So it's not something that people have looked at, but my goodness, how wonderful would that be?
I even have seen less post-herpetic neuralgia from using Tagamet,
Mm.
which is
Mhm.
which is amazing. So if you could just review the treatment for zoster again and the preventative treatment. I know we talked about it when we were talking about with simplex, but just so we keep it organized so people understand because it gets confusing between zoster and simplex.
Yeah, so with zoster, once you have an outbreak of zoster, you need to be on an oral antiviral. That oral antiviral, you're going to be on the zoster dose, which is the higher dose. Right now, there's only three available, so we're talking acyclovir versus famvir versus valacyclovir. Acyclovir, you'd be 800 3 times a day. Valacyclovir, you'd be 1,000 3 times a day, and famvir, I think, is 500 3 times a day. You might choose when Famvir first came out, it said it decreased the chances of post-herpetic neuralgia. We have found that that is not so. Now that we have many years of studying it, so there's really no difference clinically which of those you pick. You might steer clear of acyclovir if your patient is lactose intolerant, and you might choose Famvir if your patient is very elderly to decrease CNS central nervous system symptoms like agitation, hallucination. The second most important thing is zoster can affect different organ systems, not just the eye. So if the zoster is attacking a different organ system besides the eye, then you want to get them to that specialist. So if it's the eye, you're going to send them to optometry, ophthalmology. If it's the brain, we got to go to neurology, that sort of thing. And then the last thing that's really important is to manage pain. So we would do everything in our armamentarium to manage their pain. With postherpetic neuralgia, oftentimes it's gabapentin that's used. Gabapentin has a whole bunch of side effects that are unpleasant. And if someone has postherpetic neuralgia, I would send them to a pain specialist because that's chronic pain over a long period of time. Best thing you can do to prevent zoster, because you can't help getting older. Well, you can, but like that's not pleasant. Like hopefully everyone's going to get older. The best thing that you can do is to be vaccinated. So once you're 50 years old, you can get the Shingrix vaccine. It's a 2-shot series. Most kids are vaccinated for chickenpox, even now, where with people who have vaccine hesitancy. But still, chickenpox vaccine as a young child will also help prevent serious cases of zoster in throughout their life. Sometimes people are like, I don't know if I had chickenpox or not. Which vaccine is right for me? The CDC says you shouldn't be tested to figure out if you have antibodies against chickenpox to determine which one you should get. But everyone would benefit from Shingrix. What if you had the older zoster shot, which is no longer available? Should you still get Shingrix? The answer to that is yes. You should still get Shingrix because it's a better vaccine. That's why the old one was retired.
The old
Um,
one, from my understanding, worked about 50% decreased risk. How about the new one? How much does it decrease the risk? Do we know that?
so it depends on how you want to quote that statistic. So I'm going to take a quick look because I don't want to get this wrong. Shingrix.
And while you're looking at that, about up to about 20% of the people actually get post-herpetic neuralgia,
Hmm.
that where they have the bad pain and they may need pain management. And as you're looking at that, what do you think about Procara or using amniotic membranes for a zoster or a simplex patient?
Well, that's fascinating. So let me answer the first question first. So Zostavax is the name of the old vaccine, and for every 60 people that were vaccinated, one person we prevented one shingles case. But it reduced postherpetic neuralgia by about 67%. With Shingrix, for every 38 people vaccinated, we prevent one episode of shingles. Um, and its efficacy was better, especially in older patients. The problem with Zostavax is that its efficacy would decrease as a function over time. So sometimes just when our patients were the most susceptible or the most fragile, when they were older, their benefit of that vaccine had waned, and so they didn't get the protection that they needed. Interestingly, too, uh, when Zostavax was the only show in town, the amount of adults that would be vaccinated was quite low. When Shingrix came out, I don't know if you remember this, there was a run on Shingrix where everybody like they had maps on the internet showing who had a supply, who didn't have a supply. People would be put on all these waiting lists to try and get the Shingrix vaccine. In terms of amniotic membranes, and would that be helpful in simplex or zoster? So amniotic membranes are derived from the they're donated by the mother. You can suspend the amniotic membrane on cryopreserve it, suspend it, and insert it into the eye without any stitches or glue. They also will freeze dry them, in which case you introduce them to the eye under a contact lens, for example. In terms of using amniotic membranes for shingles or zoster, I've never done it. My initial response is, I'm not sure how helpful that would be. The wonderful thing about amniotic membranes is it helps, wound healing is primarily where they are helpful, but they can also be helpful for decreasing scar formation and things of that nature. And so, with HSV stromal disease, which is where the scarring happens, I'm not sure. That would be interesting to look up to see if anyone's tried that. My initial thought is I'm not sure the factors that the amniotic membrane would release would be able to get where it needs to go. But I'm not sure anyone has tried that. But my initial thought is I'm not sure that that would be helpful.
I was thinking of a non-healing ulcer type situation, but it would be interesting to see people who are using it. The cornea specialists that you work with, no, nobody, I guess nobody's really using it because you would know about it if they were.
Well, it's not been brought to my attention, so at the moment, no.
How do you explain herpes simplex virus to patients?
So I usually won't use the name herpes simplex virus right away because oftentimes when patients hear the word when they hear the word herpes, they're like, "Oh no, I have a sexually transmitted disease." And even though herpes simplex can be a sexually transmitted disease, when it's in your eye, that's not you didn't have sex to put it there. So I don't consider it a sexually transmitted disease when it's in your eye. Um, so I will usually tell them they have a viral eye infection. It's if it's affecting their cornea, I tell them that's why it hurts. Lucky for you, we don't typically have medicines that can treat viruses that are attacking the eye, but you have a particular virus where, lucky for us, we have a medicine that can help you. This is how you're going to use it. And then at the end, I'll say this particular virus that you have is called HSV for short, but it stands for herpes simplex virus. Don't worry, it's not the same as the sexually transmitted disease that you're worried about. But I usually give them all the information first so that if they have a little bit of a panic on the second bit, they will have heard and hopefully absorbed what I had to say in the first bit.
If somebody wears contacts, they get herpes simplex or herpes zoster, shingles, can they wear contact lens again when they heal?
So that's a great question. The short answer is yes. The longer answer is it depends. So when you get herpes simplex in your eye, it typically won't affect your eye to the point where something happens where you can't wear the contact lens anymore. It's not going to affect the tear film permanently. It does create a decreased corneal sensitivity. That could create problems, but if we've only had one episode, probably not. However, there are some people who think that contact lenses can trigger an episode. So if your patient seems to be one of those people where maybe they wear contacts infrequently and every time they wear one, they have another bout, then hey, let's stop. Like, we'll try everything we can to not have these things recur. With Zoster, elderly patients can wear contact lenses. I find, and maybe you do too in your practice, that, the older we get, the less likely we are to want to deal with contact lenses and more likely we are to have dry eyes or things that make contact lenses not as easy for us to wear. So I don't usually have that question with a lot of my Zoster patients, but if I did, there's nothing really with Zoster that would preclude you from wearing a contact lens. Certainly, anytime your eye is red, stop wearing your contacts. Come see an eye doctor. You might be making things a lot worse by continuing to wear that contact lens. Your eye's biggest defense is the blink and the tear film. And so your contact lens protects bacteria and viruses against your blink. So please stop wearing your contact lens. Come see an eye doctor so that we can help you out and make sure that we take care of whatever's causing that red eye.
Can stress trigger recurrences of zoster or simplex?
So zoster, I would say no, because unless you have some trouble with your immune system, you should only have one episode of zoster in your lifetime. Some people have more than that, especially if they had zoster when they were younger. Um, with simplex, stress has been implicated as a trigger for simplex. There is some data to suggest that is not true. But anecdotally, there are still people who strongly believe that stress is a trigger for simplex.
Does antiviral prophylaxis really reduce recurrences in herpes zoster and herpes simplex?
Yes, we have data. We have strong data that makes that a very easy yes to both.
And the last question, what's the biggest misconception patients have about eye herpes?
What's the biggest misconception patients have about ocular herpes? Maybe it's that it's a sexually transmitted disease. It's not when it's in your eye. When it's in your eye, sex is not how you got it to go there.
This was such a great discussion. I want to thank Dr. Mika Moy for joining me today. She's a wealth of information. She's a great speaker, as you can tell. People want to find out more about you and learn more about anterior segment disease or more about Berkeley School of Optometry. How could they do that?
So optometry.berkeley.edu is our website. For those of you who are students interested in applying, just click on admissions and then you can see how to apply to Berkeley Optometry. And then I lecture all over the place. So hopefully those of you who are doctors will see my name on a meeting at some point. I'm usually at the Academy meeting, but I hope to see you there.
Well, thank you, Dr. Moy. You're amazing. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.